Assalamualaikum and very good morning. So I am Dr. Noraliza, and this morning I am going to deliver a lecture entitled The Role of Kidney in Salt and Water Homeostasis. Before I continue, I would like to share with you what are the learning objectives required of you to know from this lecture. Number one, you need to know the concept of water balance and the importance of osmolality in its regulation. Number two, you need to differentiate between the osmotic and non-osmotic thirst. Third, you need to explain what are the role of osmoreceptors and volume receptors in salt and water balance. Fourth, you need to explain the role of these hormones, antidiuretic hormone, aldosterone, and atrial natriuretic peptide in salt and water balance. Next, you need to know how the water and sodium loads are excreted from the body. Number 6, you need to be able to explain what are the role of kidney in water, sodium, and potassium balance. And finally, you need to be able to list what are the disorders related to water, sodium, and potassium balance. So this lecture are divided into a few division, where first one I will explain about the daily water balance. Where does the water come from and how it being excreted, or what are the routes of its loss from the body. Next, how the body water being distributed. Next, maintenance of fluid and electrolyte balance that involve the role of osmoreceptor and volume receptors, the role of thirst mechanism, the role of these important hormones, antidiuretic hormone, aldosterone, and atrial natriuretic peptide, and the role of kidney in conserving and excreting excessive salts and water from the body, and what are the disorders of water, sodium, and potassium homeostasis. So the first part of this lecture is regarding the regulation of water homeostasis. So in our body of a 70 kilogram adult man, around 60% of the total body weight consisted of water. And as you can see from the table, the percentage of total body water changes as you grow older, where the percentage is more when you are in infant, and it starts decreasing as you age. And you can see also the difference between male and female, maybe because of the percentage of total fat and muscle content that distinguish the percentage of total body water. So from that 60% of total body water, so where does the body water being distributed? So around 40% of total body water are located intracellularly, whereas 20% are located extracellularly, where 5% in the plasma and 15% in the interstitial fluid, transcellular fluid, and mesenchymal tissue fluid. From that total body water, majority of the total body water are in the blood and in the kidney, followed by muscle, brain, and skin, and the least amount of body water are located in the adipose tissue. Okay, so where does that 60% of total body water come from? So majority of the total body water come from the water that you drink, ingested water, and also in the food that you eat or you ingested. And a small amount come from the metabolic process in the body. Whereas the water output are via different routes, where majority of water output are via the urine, followed by insensible loss. So insensible loss meaning water loss via evaporation from the skin or following the respiration process. Next is via the feces and also sweat. So as you can see from the table, to maintain the homeostasis in the body, the amount of water input must equal to water loss. From that total body water, the body fluid not only consisted of water, but it also consists of the cations and anions that make up the electrolytes in the body. So as you can see here, majority of sodium ion are located extracellularly, whereas potassium ion are located intracellularly, together with the other cations. Whereas the anions are located in the interstitial fluid, namely the chloride and bicarbonate ion. So next we move to what are the two factors that involve in the regulation of water homeostasis. So mainly there are two factors that involve in the regulation of water homeostasis. The first one is plasma osmolality, which will be detected by the osmoreceptor, and the second one is the blood volume, which will be detected by the volume receptor or baroreceptors. So before we proceed, we need to know what are the measurement of solute concentration in the body that make up the body fluid. So osmolality is the total number of particles of solute that make up by the sodium, urea and glucose per kilogram of water. That gives the unit of milliosmol per kilogram. So it is the primary determinant of osmolality is plasma sodium. Osmolality is independent of particle size or weight and also temperature. And normally, the osmolality of blood is similar to that of plasma, which is within the range of 275 to 295 milliosmol per kilogram. So, hypertonic solution of fluid is the one with more than 295, whereas hypotonic fluid is less than 275 milliosmol per kilogram. The other measure of solute concentration is osmolarity. As compared to osmolality, osmolarity refers to the number of particles of solute per liter of solution, which gives the unit of milliosmol per liter. And it covers the total concentration of all osmotically active solute particles in the solution, and it is dependent on the number of particles in the solution and also dependent on the temperature. So normally, the body water content and composition is very finely maintained by these two mechanisms. The first one is the hormone, which involves the antidiuretic hormone, and the second one is the thirst mechanism. The osmotic regulation in the body normally under physiologic condition involve the release of antidiuretic hormone following any changes in plasma osmotic pressure or plasma osmolarity. Normally, when the plasma osmolarity is below the threshold value, osmoreceptors are not activated, therefore the secretion of antidiuretic hormone is suppressed. However, when the plasma osmolarity start to increase and within the range of 280 to 285 milliosmol per kilogram water, it start to cause secretion of antidiuretic hormone, and the secretion of antidiuretic hormone will increase linearly following an increase in the plasma osmolarity. And with further increase in plasma osmolarity, thirst mechanism will be activated. So as we know, there are two mechanisms that involve in the regulation of body fluid osmolality. The first one is thirst mechanism. Second one is following secretion of antidiuretic hormone. So what happened is that following this mechanism, it will cause a person to start to increase water intake and cause dilution of ECF and restore the plasma osmolarity. Whereas following stimulation of antidiuretic hormone secretion, it will cause water reabsorption to occur in the kidney and water retention to occur, and eventually leads to restoring the plasma osmolarity. Before we proceed with what are the role of antidiuretic hormone, we need to know what is actually this hormone. It is also known as arginine vasopressin, and it is synthesized in the cell body of the supraoptic nuclei and paraventricular nuclei in the hypothalamus. Following synthesis, it will be transported to the posterior pituitary and secreted following a stimulus. So, excess of antidiuretic hormone will lead to syndrome of inappropriate antidiuretic hormone secretion, whereas its deficiency will lead to diabetes insipidus. So, what are the effects of antidiuretic hormone? So, antidiuretic hormone, which will be released following a change or an increase in plasma osmolality, has two main effects. The first one is the vasopressin effect on the blood vessel, where antidiuretic hormone will cause vasoconstriction and it will decrease the glomerular filtration rate and therefore will decrease the water excretion. Also, antidiuretic hormone will act on the kidney to produce antidiuretic effect, where the antidiuretic hormone will act on the V2 receptor and cause mobilization of water channel called the aquaporin channel, and that aquaporin channel will be inserted into the apical membrane of distal tubule and cells of collecting duct to cause more of water reabsorption. So what are the factors that stimulate or decrease the release of or secretion of antidiuretic hormone? It can be divided into two. The first one is called the osmotic factor, and the second one is the non-osmotic factor. The osmotic factor is mainly due to an increase in plasma osmotic pressure or plasma osmolality. So, increase in plasma osmolality will cause an increase in antidiuretic hormone secretion. Whereas the non-osmotic factor involve hemodynamic change, for example, change in the volume and pressure of the arterial, or nausea, hypoglycemia, activation of the renin-angiotensin-aldosterone system, hypoxia and hypercapnia, and stress. But if a person drink a lot of water, it will decrease the secretion of antidiuretic hormone, whereas the effect of drugs and hormones varies. Some will cause an increase, some will cause a decrease in antidiuretic hormone secretion. So, how the osmotic and non-osmotic stimuli act to cause a release in antidiuretic hormone? For example, osmotic stimuli due to increase in osmotic pressure or plasma osmolality, it will be detected by the osmoreceptor in the hypothalamus, and information will be sent to the thirst center in the hypothalamus and cause a person to drink. And also, osmoreceptor will send information to the posterior pituitary to cause a release or secretion of antidiuretic hormone, where antidiuretic hormone will act on the kidney to cause water reabsorption and water retention. Whereas the non-osmotic stimuli, for example, a reduction or blood loss, will be detected by the volume receptor, and volume receptor will send information via the hypothalamus to the posterior pituitary to cause a release of antidiuretic hormone to eventually cause water retention. One of the factors that cause a release of antidiuretic hormone is the renin, angiotensin, aldosterone system. So what does this system do? It is actually a critical regulator of blood volume and systemic vascular resistance, and it is involved in the long-term regulation of arterial pressure. So what happens is that following stimulation of this system, angiotensin will cause a release of aldosterone, which will act to increase the water and sodium reabsorption, whereas aldosterone has a direct effect on the blood vessel to cause arterial vasoconstriction, therefore reduce GFR and decrease the water excretion. Okay, now we move to the second mechanism that is involved in the regulation of body water homeostasis, which is thirst mechanism. So when talking about thirst, it can be divided into two types of thirst. The first one is osmotic thirst. Osmotic thirst is due to excessive taking of salty food. And this occurs when the fluid content within the cell decreases and causing the blood to become more concentrated, and water will be drawn from cell into the bloodstream. Whereas the second type of thirst is non-osmotic or hypovolemic thirst, which is due to fluid loss from the body, maybe due to sweating, vomiting, diarrhea, or severe bleeding. So what happened during these two types of thirst that activate the mechanism in the body is that following osmotic thirst, increase in plasma osmolality due to ingesting salty food will be detected by the osmoreceptors. So osmoreceptor will send information to the thirst center and cause increase in thirst sensation, and a person start to increase his water intake. Whereas the non-osmotic or hypovolemic thirst, which maybe occur due to severe bleeding, will decrease the blood volume, and this will be detected by the baroreceptor. So what happens is that baroreceptor will directly activate the thirst center to increase the thirst sensation. Baroreceptor will also activate the renin-angiotensin system to cause more of salt and water reabsorption. Okay, previously we have encountered a few times the volume and baroreceptors. So these are the two types of volume and baroreceptors that are present in our body. So the low pressure are also known as the volume receptor. They are the baroreceptors in large systemic veins, pulmonary arteries, arterial and ventricle walls. And these receptors respond to changes in wall tension, namely the volume changes and a marked drop in the blood pressure if it is reduced lower than 60 millimeter mercury. So, for example, if increase in blood volume will cause stretching of this receptor, and what happens is that heart rate will increase and renal vasodilation will occur. So following that, antidiuretic hormone, renin and aldosterone secretion will be decreased. A decrease in antidiuretic hormone secretion will increase the volume of urine excreted. And also stretching of the arterial wall following high blood volume will cause an increase in atrial natriuretic peptide secretion. What happens next is the increase in urinary sodium and water excretion. Whereas the high pressure receptors are the baroreceptors located within the aortic arc and carotid sinus, and it responds to stretching of the arterial wall. And these receptors are sensitive to blood pressure if it increases to more than 60 millimeter mercury. So what happens is that increase in arterial blood pressure that is detected by the high pressure receptor will cause an increase in the vagal activity to reduce the heart rate and also decrease the sympathetic activity to cause general vasodilation. Next is how the body knows when to conserve and when to excrete excess salt and water from the body, and what are the mechanisms involved. For example, if a person in a dehydrated state, for example, due to low water intake or due to excessive sweating, so what happens in the body is that plasma osmolarity will increase. So this will be detected by the osmoreceptors in the hypothalamus, and impulse or information will be sent to the third center, and the person will start to increase fluid intake. Also, osmoreceptors in the hypothalamus will send information to the posterior pituitary to increase the release of antidiuretic hormone. Next, antidiuretic hormone will act on the renal tubule to cause more of water reabsorption. So when more water reabsorption occurs, less water being excreted in the urine. And this mechanism occurs via negative feedback mechanism. And the opposite will occur if a person taking too high water intake, which will lead to reduction in the ADH secretion and decrease in water reabsorption, so more water will be excreted in the urine. So what happens is if a person taking too much of salt in the form of sodium chloride, so increased salt intake will lead to hyperosmotic volume expansion. So what happens is that high plasma osmolarity will be detected by the osmoreceptor, and again it will stimulate the third center to stimulate or increase drinking and increase antidiuretic hormone secretion to cause more water reabsorption by the kidney, therefore decrease the urine output. However, if a person is taking a lot of isotonic saline, the isoosmotic volume expansion will occur. What happens is that extracellular fluid volume will increase, and this will be detected by the volume receptor. So the volume receptor, which is the atrial stretch receptor, will send information to the medullary center to reduce the renal sympathetic discharge, therefore causing the vasodilation and increase the glomerular filtration rate. And this will lead to increased renal salt and water excretion. At the same time, atrial stretch receptor will cause release of atrial natriuretic peptide, where atrial natriuretic peptide will decrease or inhibit tubular sodium reabsorption. And also, atrial stretch receptor will cause a decrease in antidiuretic hormone secretion and reduce the renal water reabsorption. So collectively, all these effects will increase renal salt and water excretion and therefore restore the ECF volume towards normal. Next, we move to the second part of the lecture on how the body regulates or maintain the sodium homeostasis. Same like water, the sodium intake must equal to the sodium output. So the intake of sodium mainly from the diet will be absorbed in the gut and mainly are present in the extracellular fluid. So the output of sodium will occur via the sweat glands and via the feces, and majority of sodium will be excreted via the urine. So the regulation of sodium balance involves two processes, whether sodium retention via sodium reabsorption or sodium excretion. So the factors involved in sodium retention are angiotensin 2, aldosterone, hemodynamic changes, and sympathetic stimulation or inhibition. Whereas the sodium excretion is via the atrial natriuretic peptide and decrease in protein osmotic pressure. So before we proceed, What is actually atrial natriuretic peptide and how it acts? So, atrial natriuretic peptide is secreted by the myocardial cells of the arteria, and it is stimulated in response to an increase in the extracellular fluid volume or hypervolemia. So what happens is that this tension of the arterial wall will be detected by the stretch receptor in the atria and cause a release of atrial natriuretic peptide, whereas this tension of the ventricular wall will be detected by the stretch receptors in the ventricle and cause a release of brain natriuretic peptide. Following a release of the two type of natriuretic peptide, it will cause decrease in reabsorption of sodium and water by the kidney and therefore restore the blood volume towards normal. So how atrial natriuretic peptide produces its effect in order to reduce the blood volume towards normal? So the first one is that by increasing the sodium and water excretion. So what does it do is that it will cause dilatation of the efferent arterioles. So glomerular filtration rate will increase and filtered sodium load will increase. And also it acts on the renal tubule to decrease the number of open sodium channels in the principal cells and therefore reduce the sodium reabsorption. Second, ANP will cause an increase in the capillary permeability. So it will then lead to extravasation or leakage of fluid from the capillary, which will contribute to reduction in the blood pressure. Third one is ANP will cause vasodilation. And fourth, it will inhibit secretion of renin and aldosterone and therefore decrease the reabsorption of water and sodium. So the effect of ANP is basically antagonistic to the effect of catecholamine and angiotensin II. So in summary, what does ANP do following high sodium intake, or how does high sodium intake being regulated is that high sodium intake will lead to increase in plasma sodium concentration. So this will cause an increase in plasma osmolality. Increase in plasma osmolality will be detected by the osmoreceptor, which will send information to the thirst center to cause increase in fluid intake to increase the ECF volume. Following increase in ECF volume, increased glomerular filtration rate will occur and more sodium and water excretion will occur. Also, stimulation of osmoreceptor will cause an increase in the antidiuretic hormone secretion. So following release of antidiuretic hormone secretion, it will lead to water reabsorption and water retention, therefore increase in the ECF volume. So increase in ECF volume will later cause secretion of ANP secretion. So what happens is that ANP will act directly on the kidney tubule or renal tubule to decrease the tubular sodium reabsorption. And increase in ANP will also inhibit the effect of aldosterone, therefore decrease the tubular sodium reabsorption. All this cumulative effect will lead to increase in water and sodium excretion. Next, we move to the regulation of potassium homeostasis. Similar to water and sodium, in order to maintain the potassium balance, the intake must equal to output. And mainly, potassium are distributed more intracellularly. And the serum potassium level is between 3.5 to 5 millimole per liter. So the mode of potassium output is mainly via the urine and in the feces. So for the potassium balance, it involves two factors, the internal and external balance of factors. So the internal balance are contributed by the distribution of potassium ion in the ECF and ICF, and it is regulated mainly by aldosterone, insulin, and catecholamine, also by the acid-base balance, changes in osmolarity, exercise, and cell lysis, whereas the external balance are contributed by the renal reabsorption at the proximal convoluted tubule and thick ascending limb of loop F. Henle, and excretion of potassium at the distal convoluted tubule and collecting duct. So these are the factors that influence the shift of potassium into the cells, and another factors that cause shift of potassium out of the cell. So the factors that shift potassium into the cells are insulin, aldosterone, alkalosis, adrenaline, anabolism, and hypothermia, where the opposite of the factor that cause a shift of potassium into the cell is diabetes mellitus, which cause insulin deficiency, Addison disease, which cause aldosterone deficiency, acidosis, blockage of the beta-adrenergic receptor, exercise, and cell lysis. Okay, in this slide shows whether sodium intake influence the potassium excretion. So normally, high sodium intake will reduce aldosterone secretion. So what happens is that reduction in aldosterone will decrease the potassium secretion by the collecting duct. And also, increase in sodium intake will increase the glomerular filtration rate and decrease the proximal tubular sodium reabsorption. So what happens is that there will be an increase in fluid delivery to the collecting duct, which will increase the potassium secretion. So the opposing effect of high sodium diet, one cause a decrease in potassium secretion, another one will cause an increase in potassium secretion, will eventually cause the potassium excretion unchanged. Okay, next we move to the disorders of water homeostasis. So what can cause disorders of water homeostasis despite a normal regulation that help to maintain the water homeostasis in the body? So it occurs in this condition called the diabetes insipidus. In diabetes insipidus, there is a large volume of passage of urine, and also diluted urine will be passed in the from the body. So following a passage of large volume of urine, following polyuria, that will also cause polydipsia, excessive thirst, and also nocturia, excessive excretion of urine at night. And following passing a large volume of urine will lead your body to become dehydrated, and your body will show this sign and symptom. For example, dry mouth, changes in the skin elasticity, reduce the blood pressure, increase in sodium concentration, fever, headache, rapid heart rate, and also weight loss. There are different types of diabetes insipidus due to the different cause and reason. So the first type is called the nephrogenic diabetes insipidus. So what happened in nephrogenic diabetes insipidus is that secretion of antidiuretic hormone is normal. So what abnormal is that the receptor is resistant towards the antidiuretic hormone. Therefore, antidiuretic hormone cannot act on the kidney tubule to be involved in the urine concentrating mechanism. Therefore, the person will pass a large amount of diluted urine. So the cause of nephrogenic diabetes insipidus can be due to genetic disorder or due to chronic kidney failure or disorder, chronic kidney disorder. And nephrogenic diabetes insipidus usually affects male, but if it occurs in women, it can pass the gene to their children. Second type of diabetes insipidus is called the central diabetes insipidus. So in central diabetes insipidus, they are damaged to either hypothalamus or the pituitary gland, which will disrupt the normal production, storage, and eventually release of antidiuretic hormone. So a reduction in the production, storage, and release of antidiuretic hormone in central diabetes insipidus can be due to post-surgery, tumor, meningitis, inflammation, or head injury that cause damage to the hypothalamus or pituitary gland. So this is what happened in diabetes insipidus. Okay, normally antidiuretic hormone will bind to its receptor, P2 receptor, and cause water reabsorption to occur at the collecting duct and involved in the urine concentrating mechanism. However, in the nephrogenic diabetes insipidus, the receptor are not responsive to the antidiuretic hormone, and therefore it cannot produce the urine concentrating mechanism effect. Next type of diabetes insipidus is called the gestational diabetes insipidus, or also known as hypotonic polyuria of pregnancy. This type of diabetes insipidus is rare and normally occurred only during the third trimester. So what happened is that in this pregnant mother, there will be excessive oxytocinase or vasopressinase activity, where this enzyme, which is produced by the placenta, will destroy the antidiuretic hormone. Therefore, antidiuretic hormone cannot produce the urine concentrating mechanism and causing the passing of the large volume and diluted type of urine. And this condition can also contribute to diabetes insipidus called the primary polydipsia, where prolonged excessive water intake may itself damage the kidney and also suppress the antidiuretic hormone. So there are two types of primary polydipsia that leads to diabetes insipidus. The first one is dipsogenic diabetes insipidus, where this results from abnormal thirst and causing damage to the hypothalamic thirst regulating mechanism. And the second one is psychogenic diabetes insipidus, where this person also experience abnormal thirst and therefore drinking a lot of water and eventually will depress the antidiuretic hormone secretion and decrease the aquaporin expression in the kidney. So next is disorder of sodium metabolism. What happens if the body cannot control the level of sodium within its normal range? So mainly there are two conditions involved here. Hypernatremia, where the sodium level in the serum is more than 145 millimole per liter. So the hypernatremia can be present in three different conditions. The first one, hypernatremia with ECF volume depletion, for example, following sweating, vomiting, diarrhea, or diuretic medication. And second one is hypernatremia with normal extracellular fluid volume, which can occur during fever or diabetes insipidus. And the third one is following hypernatremia with excess ECF volume, where this can be due to hyperaldosteronism, where we know that aldosterone involved in sodium and water retention. So excess in aldosterone will cause excessive sodium retention, leading to hypernatremia, or due to excessive administration of IV fluid of 3% normal saline, or from eating too much salt. This condition can lead to hypernatremia. The second abnormality or disorder of sodium metabolism is hyponatremia, and it occurs if the serum sodium level less than 135 millimole per liter. So similar to the hypernatremia, it can occur with ECF volume depletion in diuretic-induced adrenal insufficiency or with normal ECF volume, which occur following glucocorticoid deficiency, or it can occur with excess ECF volume in chronic heart failure, hepatic failure, or nephrotic syndrome. Next, also disorder of potassium metabolism. Similar to sodium, it can be due to hypo or hyperkalemia. So hypokalemia if the serum potassium less than 3.5 millimole per liter, or hyperkalemia if more than 5.5 millimole per liter. Hypokalemia can be due to low potassium intake or shift of potassium from ECF to ICF due to the factors explained, and also due to increase in potassium excretion. And hyperkalemia can be due to high potassium intake, potassium shift from ICF to ECF, or very low potassium excretion. So from the very beginning of this lecture, I have explained about the mechanism, factors, and how the body regulate normal fluid which involve water and electrolytes balance, and it involves the brain, the hypothalamus, the posterior pituitary, and also the kidney to cause reabsorption of water and all the electrolytes in order to maintain its homeostasis. So it needs interaction between a combination of a few factors and organs. All right. So with that, I thank you for listening. And any question, you can just email me or WhatsApp me, and can also contact me by using the platform used by the university. Thank you and Assalamualaikum.